What if one pharmacology mistake cost you a passing score? Drug mechanisms, adverse effects, and interactions show up throughout the PEBC Evaluating Exam. And the good news is, once you see the patterns, these questions become some of the most predictable on the entire test. Let's break it all down right now. Here's the thing about pharmacology on the evaluating exam. It doesn't live in a bubble. Mechanism questions are often dressed up as patient scenarios, asking you to predict what happens when a drug is added or removed. The examiners aren't just testing whether you memorized a receptor. They want to know if you can apply that knowledge. So our whole approach today is pattern-based. Learn the mechanism deeply, and the ADRs and interactions almost explain themselves. That's the mindset shift that separates struggling candidates from confident ones. Let's start at the foundation. An agonist mimics the natural ligand. It binds and activates. An antagonist binds but does nothing on its own. It just gets in the way. Partial agonists are interesting because they can act like agonists when nothing else is around, but they actually reduce the effect when a full agonist is competing. Buprenorphine is a classic example, partial mu-opioid agonist. And inverse agonists? They flip the receptor into an inactive state below its baseline. Understanding these four categories means you can predict drug behavior in combination scenarios, which is exactly what EE questions love to test. ADME is your pharmacokinetics cheat code. Absorption tells you how much drug gets in. Distribution tells you where it goes. A high volume of distribution means the drug is hiding in tissues, not plasma. Metabolism is where most drug interactions live, especially CYP450. And elimination determines dose adjustments in renal or hepatic impairment. When you see a drug interaction question, run through ADME in your head. Is one drug inhibiting a CYP enzyme that metabolizes the other? That's your answer. We'll dig into CYP in just a moment, but keep ADME as your mental checklist every single time. CYP450 interactions are probably the highest yield pharmacology topic for the EE. Here's the logic. If drug A inhibits the enzyme that breaks down drug B, then drug B accumulates. That's a toxicity risk. If drug A induces the enzyme, drug B gets cleared faster. That's a treatment failure risk. The CYP450 mnemonic helps with CYP3A4 inhibitors, sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, amiodarone, clarithromycin, erythromycin, sulfonamides. For inducers, think CRAP GPS, carbamazepine, rifampin, alcohol chronic, phenytoin, glucocorticoids, phenobarbital, St. John's wort. Drill these lists and you'll recognize interaction patterns instantly. Not all adverse drug reactions are created equal. Type A reactions are an extension of the drug's own mechanism. They're predictable and dose-related. Too much insulin causes hypoglycemia. Too much warfarin causes bleeding. You can anticipate and manage these. Type B reactions are the scary ones. They're idiosyncratic, meaning they're independent of dose, often immune-mediated or genetically driven. Stevens-Johnson syndrome with carbamazepine, a granulocytosis with clozapine, or hepatotoxicity with isoniazid are classic examples. When an EE question describes a reaction that doesn't make pharmacological sense at the dose given, think type B. This classification also guides counseling. Type A reactions can sometimes be managed by dose reduction. Type B usually means stopping the drug. Let me give you a rapid-fire set of ADR pairs that come up again and again in clinical scenarios. ACE inhibitors cause a dry, non-productive cough because they prevent bradykinin breakdown. Switch to an ARB if it's intolerable. Statins can cause myopathy, ranging from mild muscle aches all the way to life-threatening rhabdomyolysis, especially when combined with CYP3A4 inhibitors like clarithromycin. Fluoroquinolones have a black box warning for tendon rupture and can prolong the QT interval. And metformin, while generally safe, can accumulate and cause lactic acidosis when renal function drops. Always check eGFR. These aren't random facts. Each one is tied to a mechanism you already understand. We've talked a lot about pharmacokinetic interactions, where one drug changes the levels of another. But pharmacodynamic interactions are just as important and often more intuitive. Additive interactions happen when two drugs do the same thing. Two antihypertensives both lower blood pressure. Synergistic interactions are more than additive. Trimethoprim and sulfamethoxazole together block folate synthesis at two sequential steps, making the combination far more effective than either alone. Antagonistic interactions occur when one drug opposes the effect of another. Naloxone reversing opioid effects is a pharmacodynamic antagonism. The opioid-benzodiazepine combination is a critical safety example. Both depress the CNS, and together they dramatically increase respiratory depression risk. The EE loves these real-world safety scenarios. This is a conceptual trap that catches a lot of candidates. Tolerance means the body has adapted and you need a higher dose to get the same effect. Think opioid tolerance developing over weeks. Dependence means the body expects the drug and removing it causes withdrawal. Here's the key. These are independent phenomena. A patient can develop tolerance to the analgesic effect of morphine without necessarily being dependent. And physical dependence, where stopping causes physiological withdrawal, is distinct from psychological dependence, which is a behavioral and craving-driven state. EE scenarios around substance use disorders, opioid therapy, and benzodiazepine tapering rely on you keeping these definitions clean and separate. Here's the 4-step framework I want you to use every time you hit a pharmacology scenario question. First, lock in the drug class and its core mechanism. Don't skip this even if you think you know the answer. Second, ask yourself what effects follow logically from that mechanism, because ADRs are usually just the mechanism pushed too far. Third, scan for interactions. Is there a CYP inhibitor or inducer, or are two drugs doubling up on the same system? Fourth, apply it to this specific patient. Do they have renal impairment, liver disease, age-related pharmacokinetic changes? That 4-step process turns a daunting question into a manageable one. Practice it on every question you do, not just the hard ones. If today's video clicked for you, I want to point you to something that goes much deeper. We've put together a detailed study guide and question bank specifically covering pharmacology mechanisms, ADRs, and interactions for the PEBC EE. You can grab it right now at our Etsy shop. The link is in the description below and pinned in the comments. Got a specific drug interaction or ADR that's been confusing you? Drop it in the comments. I read every single one, and I'll answer or make a follow-up video. And if you want to be the first to know when we drop new PEBC study content, hit that subscribe button right now. You're putting in the work. Let's make sure it pays off.